So we had unconditional cash transfer, an insurance product, and now we are going to a microcredit loan. It's a randomized evaluation from Western Kenya, and which is in East Africa. So I suggested at the beginning of the talk that we have case studies from Western Africa and South Asia. That's not true. So over to you, Shiva. Yeah.
Okay, thank you. Good afternoon, everybody. So I'll be moving from the studies from South Asia to Sub-Saharan Africa. So in this presentation, I'll be discussing about the results that we obtained from the livelihood intervention that comprised of agricultural component as well as financial component that targeted adults infected with HIV, and how that livelihood intervention had an effect on children living in HIV-affected households in Western Kenya. So what we find is in Sub-Saharan Africa, HIV/AIDS and household food insecurity, they are the major public health issues. And when they coexist with each other, then the consequences are more severe. And what we have seen from the literature is that the people living with HIV has increased to more than 20 million in 2017 from 17 million in 2000. Similarly, severe household food insecurity also has increased from 28% in 2014 to 31% in 2016. So this map shows the HIV prevalence by administrative units in Sub-Saharan African countries. What we see here is that the darker color represent higher HIV prevalence, whereas the lighter color represents lower prevalence. And what we see here is that the high prevalence of HIV is towards southern part of Sub-Saharan Africa. But when we look at the micro level, what we find is even with the countries towards the eastern part of Africa, the local or regional provinces have also high prevalence of HIV. As in case of Kenya and the Nyanza region, we see higher prevalence of HIV in that region. So where is the gap? So why do we want to study this kind of things? So from the literature and substantial prior work assessing the impact of nutritional programs on health outcomes of general children, those who are non-HIV infected, we see there are so many works. And there are also successful agricultural interventions such as homestead food production or community gardens that incorporate agricultural training. And we have seen from those studies that they have helped to improve dietary intake of mothers and children, growth among children under 5 years old, household food insecurity. However, these agricultural interventions had targeted adults and children without HIV/AIDS. So what we wanted to do is we wanted to look at the livelihood intervention which was provided to the households which had HIV-infected adults, and whether that livelihood intervention had some positive effects on children living in those households or not. So the study was conducted in Nyanza region in Western Kenya. The population there is mostly rural, and they are culturally homogeneous. The major source of livelihood is subsistence farming and or fishing. The major crops for consumption are maize, sorghum, and cassava. And this region is mostly vulnerable regions to food insecurity, and it has also higher prevalence of HIV. So what we see in this slide is, this is the conceptual model of household, caregiver, behavioral, and child health outcomes of the intervention. So the intervention consisted of 3 major components. So first one is the providing agricultural training that was provided by Ministry of Agriculture from Kenya. And second component was provision of human-powered pump provided by Kickstart, and other inputs were also provided. And a third component was provision of small amount of loan. It was about $150, and that was provided by Adoctimo, a microfinance company in Nyanza region. So after the provision of these intervention, what we hypothesize is that it helps to increase household food insecurity as well as household wealth, which leads to better caregiver outcomes, behavioral outcomes, and child health outcomes. In this study, we'll be focusing on two major outcomes: infant and young child feeding with a dietary intake of children and somatic growth of the children. So the study was nested randomized control trial. So as I said that it was the study that used the households from parent study where the adults were HIV infected, and two health facilities supported by family aids care and education services were randomly assigned as intervention or control arm. The eligibility for parent study was the adults had to be 18 to 49 years old, HIV positive, they should be receiving antiretroviral therapy, they should belong to patient support group, willing to save a down payment of small, about $6 required for the loan, and they should have evidence of moderate to severe household food insecurity that was calculated based on household food insecurity assess scale, and or BMI less than 18.5, and they should have access to farming land and available surface water for irrigation. So the participants for this study were 100 children in each arm and their primary adult caregivers. The inclusion criteria was the children should have to be of 0 to 59 months of age, and their primary caregivers should reside in compounds enrolled in the parent study. And we excluded children who had severe acute malnutrition. So we collected data in starting from April 2012 and followed the children for 1 year at 3 months in interval. The outcomes were dietary intake calculated as frequency of 10 food groups. We obtained the 10 food groups out of 63 individual food items that were asked to the participants, and the other outcomes were height, weight, and mid-upper arm circumference. And we use intent to treat repeated measures analysis using XT-reg command in Stata. Linear trends over months in control and intervention arms were calculated. Difference between arms in trend across months from 0-month visit to 12-month visit was also calculated, and we used a p-value of less than 0.05 to use as a cutoff for the statistical significance for drawing inference. So in this graph, we see fitted lines of weight of children across the months for control and intervention arms. So the red line represents the fitted line of weight of children in intervention arm, whereas the blue dotted line shows the fitted line of weight of children in the control arm. And what we see here is that across the months and compared to the control arm, the children who were in the intervention arm had increased weight. So when we look at the frequency of consumption of different foods, we found significant increase in consumption of overall diet, consumption of staple foods, fruits and vegetables, meat, fat, and sugar. There was no significant decrease in, there was also significant decrease in consumption of condiments and tea or coffee, and we did not find any significant differences in consumption of legumes, dairy, and eggs. In addition to this, we also did not find any significant difference in height and mid-upper arm circumference of the children between two arms. So I would also like to point out some limitation of this study, because we selected only 2 health facilities which prevented definitively separating the intervention effects from potential other factors and accounting for variation among health facilities. In addition, this was a 12-month follow-up. This study had only 12-month follow-up period, which perhaps might not be long enough to test the differential effects for other anthropometric outcomes, especially height of the children. And we cannot generalize the findings of this study to other populations, because this was focused on children affected by HIV/AIDS. So I would like to have this conclusion. So after a year of the intervention, the children had improved weight, overall frequency of consumption of food, consumption of staples, fruits and vegetables, meat, fat and sugar. The children had decreased consumption of condiments and tea or coffee. So the livelihood interventions targeted to adults with HIV/AIDS also have substantial benefits to children living in those households. So this study might inform design and scale up of evidence-based agricultural interventions targeting HIV-affected households. So I would like to conclude my presentation leaving these slides of acknowledgements. Thank you.